Well, there are differences and similarities. The difference is actually morphologic. Central sleep apnea, there is no effort being generated. Obstructive apnea, effort is being generated. The driver for central sleep apnea is cessation of ventilatory motor output. The brain simply, the medulla, is turned off transiently. It's like turning off and on a switch. The driver for obstructive sleep apnea is closure of the upper airway. However, having said that, we have to realize that these two things are intertwined. The etiology is not as separate as we may think. Morphology does not equate etiology. For example, decreased drive, meaning central apnea or central hypopnea, could result or will result in upper airway narrowing or closure in a susceptible individual. Conversely, if you have an obstructive apnea and you resulting in significant desaturation, the arousal and the prolonged hyperventilation that happens or a sigh that happen could trigger a central apnea. So we have to think of these two entities as organically intertwined, not two separate, isolated entities just based on morphology. Well, there's a whole list of things. We start usually with the two biggest causes are heart failure with reduced ejection fraction, and another one which is unfortunately has become more common is opioid use. These are kind of the biggest ones that affect the population. Now there is a group we have absolutely no cause for it. We call it primary. There are several medical conditions that could be associated with central sleep apnea. And there is one actually that is very physiologic. If you go to high altitude, there is more likelihood of actually developing central apnea at high altitude, say at 8,000 feet. Now, one of the things that are missed in this conversation is that there are, even in healthy population, there are differences in central apnea. For example, men are way more likely to develop central apnea than women. That's why it's very it's uncommon on a polysomnogram to see a young woman who has central apnea. However, once a woman reaches menopause, her risk of developing central apnea increases. To add a layer of complexity to this, aging per se in men and women increases the likelihood of central apnea. And again, at the end, there is a group of people who they have central apnea for no reason that we could identify, and we call it primary. Well, CPAP, continuous positive airway pressure, is the first line therapy, and it's efficacious in about 50%, 50 to 60% of the population. Now, one important point to note is that most of the treatments that we currently have, and I'm saying most, not all, for the treatment of central apnea are repurposed from obstructive apnea. So CPAP is very effective for obstructive apnea, 95% efficacy, okay? And it's about 50% efficacious in central apnea. Adaptive servoventilation works in the group where CPAP didn't work. And it worked by a slightly different method and a different, basically, driver, which is preventing the person from hyperventilating and developing another apnea. And it's efficacious in the majority of the population. However, one other factor to consider, that a large number of patients who have central apnea have comorbid obstructive apnea. So it's not very common to see somebody who has pure central apnea and no obstructive apnea. And that may be one of the reasons why CPAP is very effective. So these are the two original therapies. They're all variations of positive airway pressure. Okay, so the first treatment by every set of criteria is CPAP. That we know has high efficacy. And I'm distinguishing efficacy from effectiveness, because if people don't use it, it's not effective. And it works about 50 to 60% of the patients. And that's our first line therapy. Now, in patients where it doesn't work, there are other options that work for central apnea. For example, supplemental oxygen is efficacious in a good number of patients with central sleep apnea. The problem with this is that it is not always easy to qualify a patient for supplemental oxygen if they don't have periods of non-apneic desaturation, meaning you've eliminated the central apnea and they continue to have desaturation. It's difficult to be able to qualify patients for it. Another one is actually adaptive servoventilation, which is it's a variation of positive pressure, but it's designed in a way to mitigate hyperventilation and preventing the decrease in CO2 or the hypocapnia that causes central apnea. Now, there are novel therapies, and we're talking about novel therapy, is a phrenic nerve stimulation. Now, this historically was used in a different variety, in a different method for individuals with high spinal cord injury. But now this is done transvenously, and it stimulates one side of the diaphragm. And that's a promising new treatment that could actually be very effective in the future. But again, the relative experience with it, it's still expanding. It's not everywhere yet. Now the horizon is, if we think of central apnea as happening as something abolishing the ventilatory drive from the medulla, pharmacological interventions are probably going to be the way of the future. But where, we don't know yet. Well, the phrenic nerve stimulation is a promising novel treatment. And again, like anytime we have a novel treatment, we have to be careful, methodical, understand where it works and where it doesn't work, and apply it methodically for the right patient. And again, this is a novel treatment that it will take a while before centers are able to do it. This is probably not going to be the one that will be done in every sleep center. It will be in places that are specialized, because a sleep physician will not be the one who will be inserting the device. It'll be an interventional cardiologist. So it has to be part of a larger program for care. The third one, the second is, as I mentioned, pharmacological therapy. But one thing I would like to add, which is not usually discussed because it doesn't fit in standard guidelines, is a good number of patients, about 2/3 of the patients with central apnea have obstructive apnea as well. So I would envision that many future interventions will involve CPAP plus another intervention, CPAP plus oxygen, CPAP plus a medication. Because if we correct the central apnea but leave the obstructive apnea untouched, we haven't helped you. So for the 2/3 of the patients who have both, it will probably be treatment of both conditions.